But, usually when we think about the human body healing itself, there's this underlying expectation of comforting simplicity.
Oh, absolutely. We completely take it for granted.
Right, like you get a minor scrape or a paper cut, your body just sort of senses the damage, it builds a tiny little scab, and I mean, a few days later, it's like it never even happened.
Yeah, it feels entirely routine, clean,
Yeah,
automatic.
exactly. But the moment you look closer, like the second you step into the microscopic world of vascular pharmacology, that comforting simplicity just vanishes.
It really does. You realize you're looking at a biological landscape that is, well, frankly, terrifyingly precise.
So today's deep dive takes us directly into that landscape. We're going to decode the high-stakes biological balancing act of bleeding and clotting.
The ultimate tightrope walk.
Yeah, exactly. We're looking at the heavy-hitting drugs that medical professionals use to treat coagulation disorders. So we've got the anticoagulants, the antiplatelets, and the thrombolytics.
And our mission here is to understand exactly how the body stops bleeding, what happens when that exact same life-saving process turns deadly, and, the profound pharmacological arsenal used to intervene.
Because we're going to explore all of it. The severe box warnings, the pharmacokinetics, the nursing implications.
And the life-saving antidotes, right, the stuff that keeps patients right on the razor's edge of survival.
Which brings up the ultimate paradox at the center of all of this. I mean, the exact same biological mechanism that saves your life when you get that paper cut is the exact same mechanism that causes strokes, heart attacks, and pulmonary embolisms.
Right. It's this high-stakes balance between maintaining the fluid dynamic of your blood and, well, preventing your vascular system from leaking.
I always try to visualize this at a molecular level to make sense of it.
Oh, analogies are the best way to grasp this. What's yours?
Okay, so if we think about normal hemostasis, the body's way of stopping bleeding, imagine millions of tiny inactive strands of loose rebar just floating harmlessly in your bloodstream.
Okay, I like this. That's the fibrinogen.
Right, fibrinogen. And you also have a chemical welder just waiting in the wings, an enzyme called thrombin.
Yep.
So when a blood vessel tears, the welder gets activated. It instantly fuses those loose rebar strands into this massive tangled iron net called fibrin.
And that net catches the red blood cells and platelets to plug the hole.
Exactly. It's this localized, highly controlled construction site.
That rebar and welder analogy perfectly captures the structural mechanics. And normal hemostasis is an incredibly elegant sequence. I mean, it begins with localized vasoconstriction to immediately slow the blood flow down.
Like pinching a hose.
Right. Then you get the formation of a temporary platelet plug. Those platelets actually release chemical distress flares to attract even more platelets.
Oh, wow. So they're calling for backup.
Exactly. Following that, you have the sequential activation of clotting factors, the
Yeah.
coagulation cascade, which ultimately activates your welder.
The thrombin.
Yes, the thrombin, to build that fibrin net. But the elegance doesn't actually stop there. When that clot is forming, an inactive protein called plasminogen binds to the fibrin rebar.
Wait, it weaves itself into the clot.
It literally weaves itself into the architecture of the clot. It just sits there,
Inside the scab, just waiting.
waiting for the vessel to heal. And once the tissue is repaired, that trapped plasminogen is activated into an enzyme called plasmin or fibrinolysin.
And what does plasmin do?
Its solitary job in the human body is to digest the fibrin meshwork and dissolve the clot from the inside out.
That is wild.
Yeah, your body is constantly forming and dissolving microclots to keep the blood fluid and the pipes clear. Disease only occurs the second that balance between clot formation thrombogenesis and clot destruction thrombolysis is tipped.
And this dangerous clotting, it happens in two very different physiological environments, right? Which I assume completely dictates the type of pharmacological weapon a doctor will choose.
Absolutely. We have to draw a really hard line here between arterial thrombosis and venous thrombosis.
So let's start in the arterial system. We're dealing with high-pressure, fast-moving blood.
Right, arteries are high pressure. And the injure of an arterial clot is usually turbulent blood flow combined with atherosclerotic plaque.
So like cholesterol buildup.
Yeah, that turbulence physically damages the smooth, Teflon-like endothelial lining of the artery. And when that lining is damaged, the underlying collagen is exposed.
And platelets do not like exposed collagen, right?
Platelets are highly reactive to it. They assume a massive catastrophic injury has occurred, so they aggregate immediately.
Which is pile on.
Exactly. And because arteries feed freshly oxygenated blood to your tissues, an arterial clot cuts off the oxygen supply. This causes local tissue ischemia.
Ischemia meaning lack of oxygen.
Right. And if the obstruction is absolute, you progress to infarction, which is the irreversible death of the tissue.
So this is the exact pathophysiological mechanism behind, like, an ischemic stroke in the brain or a myocardial infarction, a heart attack.
Exactly. The pathology is driven by speed and pressure.
But if we move over to the venous system, the rules of the game completely change, don't they?
Completely. Veins are a low-pressure environment. We aren't dealing with high-speed turbulence here. We are dealing with venous stasis.
Stasis. So slow-moving, sluggish, or entirely pooled blood.
Yeah. And that contrast is vital for understanding the pharmacology later.
But wait, why does slow-moving blood spontaneously form a clot? I mean, if the vessel isn't damaged, like in the artery, why would it clot?
That's the million-dollar question. So under normal, healthy flow, the blood continuously sweeps away procoagulant substances. These are the chemical triggers that initiate the clotting cascade.
Okay, sweeps them away to where?
To the liver, where specialized macrophages called Kupffer cells filter them out and basically destroy them.
Oh, I see.
But imagine sitting on like a 14-hour international flight, or a patient on strict bed rest after orthopedic surgery. The blood just pools in the deep veins of the legs.
So those triggers aren't getting swept away to the liver anymore.
Right. They concentrate in one localized pocket of the vein, reach a critical threshold, and they trigger the welder. The fibrin net starts forming simply because the blood is standing still.
Wow. And that is deep vein thrombosis, or a DVT.
Yes, the blood backs up behind the clot, causing local congestion, swelling, warmth, and inflammation in the leg.
But here is the most chilling part of a DVT that we found in the source material. 50% of patients have absolutely zero symptoms.
It is a completely silent threat growing inside the leg.
A silent threat with catastrophic potential, right?
Absolutely. Because unlike those tightly packed, platelet-heavy arterial clots, a venous thrombus is predominantly a loose mesh of red blood cells and fibrin. It is highly fragile.
So a piece can break off.
Easily.
Wow.
And the moment it detaches, it is classified as an embolus. It travels up the venous system through the increasingly larger veins of the legs and abdomen.
Passes through the right atrium and right ventricle of the heart.
And gets pumped directly into the pulmonary arteries of the lungs.
Where the vessels suddenly get microscopically small again.
Right. Exactly. It slams into the pulmonary circulation, causing a pulmonary embolism, a PE.
Which could be instantly fatal, right?
Oh.
Because it cuts off the blood's ability to pick up oxygen entirely.
It's one of the most terrifying medical emergencies. So when a patient is at high risk for these hidden venous clots or already has one, we have to alter the chemistry of their blood.
We turn to the classic anticoagulants.
Yes. Let's bring in the heavy hitters, heparin and warfarin.
And there's a massive public misconception we need to clear up immediately about these drugs. People universally refer to them as blood thinners.
Oh, I hear it every day.
But they do not actually thin the viscosity of the blood.
Not at all. And more importantly, they possess absolutely zero ability to dissolve a clot that is already there. They cannot break down existing fibrin.
So what does an anticoagulant actually do?
It halts the progression, it stops the formation of new clots, and prevents an existing clot from expanding. Okay, by doing this, it buys the body time, right? Allowing the naturally occurring plasmin we discussed earlier to slowly digest the existing clot over days or weeks.
Exactly. It holds the line while the body does the cleanup.
Let's dive into heparin first, because the history and sourcing of this drug are just fascinating to me.
Oh, it's wild. Heparin is an endogenous substance, meaning human beings naturally produce it.
Right, in our mast cells, primarily in the liver and lungs to help regulate local blood flow.
But to get the massive pharmaceutical quantities needed for hospitals, the exogenous heparin in those 5E bags is harvested from animal tissue.
Specifically bovine lung or porcine intestinal mucosa, so cows and pigs.
Yeah. We are utilizing the biological byproducts of cows and pigs to artificially manipulate human coagulation. It is a profound example of biological conservation across species.
That's incredible. So pharmacologically, how does heparin work?
Well, it acts as the prototype anticoagulant. Its mechanism of action is incredibly specific. Heparin molecules bind to a naturally occurring protein in human plasma called antithrombin III. Okay, antithrombin III.
And when heparin binds to it, it causes a conformational change. It alters the shape of antithrombin III, hyperactivating it.
Like flipping a switch.
Exactly. This supercharged complex then aggressively hunts down and inactivates specific clotting factors circulating in the blood, primarily factors 9X, X, and 12.
Crucially, it inhibits the conversion of prothrombin to thrombin. So, returning to our analogy, heparin basically unplugs the power source to the welder.
Yes, Perfect way to put it. The welder has no power.
Now, I always assumed you could just take heparin in pill form, like an aspirin. But looking at its molecular size and its heavy negative charge, the human gastrointestinal tract just obliterates it.
Yeah, it cannot cross the membranes of the GI tract at all. It has to be administered parenterally.
Meaning via an IV or injection.
Right, and the administration route dictates the onset of action entirely.
How so?
Well, if a nurse administers heparin via an intravenous injection or a continuous 5V infusion, the action is immediate. It hits the bloodstream and alters coagulation within seconds.
And if it's injected?
If it is given subcutaneously injected into the deep fatty tissue, typically in the abdomen it absorbs much slower, taking about 20 to 30 minutes to achieve a therapeutic effect.
Okay, so the clinical uses must cover a pretty wide spectrum then.
They do. It is used prophylactically in lower doses to prevent DVT in patients on bed rest or undergoing major abdominal or orthopedic surgeries.
But it's also used therapeutically,
Yeah.
right? In much higher continuous IV doses.
Yes, to actively manage an acute BVT or a pulmonary embolism that is threatening a patient's life right now.
And the text also mentioned it's the primary pharmacological intervention for a really complex condition called DIC, disseminated intravascular coagulation.
Yeah, DIC is a complete paradox. It usually occurs secondary to massive trauma, severe sepsis, or certain pregnancy complications.
What exactly happens?
The body's inflammatory response goes haywire, triggering widespread, chaotic clotting all over the vascular system. The body uses up every single available clotting factor and platelet to build these millions of useless microclots.
So the body entirely depletes its own supply of rebar and welders.
Yes, and because the supply is exhausted, the patient then begins to spontaneously, uncontrollably hemorrhage from everywhere.
Wow. Foresights, mucous membranes, internal organs.
Exactly. And the treatment for this catastrophic bleeding is, counterintuitively, to give them a massive dose of heparin, an anticoagulant.
Wait, really? Using a blood thinner to stop a bleeding crisis?
I know, it sounds crazy. But the goal is to aggressively shut down the chaotic clotting process long enough for the liver to manufacture a fresh supply of clotting factors.
So the patient can actually establish normal hemostasis and stop bleeding. The physiological logic is brilliant, but the clinical execution must be terrifying.
It really is. Now, there's another vital pharmacokinetic detail here regarding pregnancy.
Right, because heparin is a massive, highly polarized molecule.
Yes, and because of its size and charge, it absolutely cannot cross the placental barrier, and it is not secreted in breast milk.
Which makes it the unequivocal anticoagulant of choice for pregnant patients who require protection from thromboembolism.
Exactly. But administering heparin carries severe continuous risk. The Institute for Safe Medication Practices actually classifies heparin as a high-alert drug.
Because hemorrhage is the primary and ever-present adverse effect.
Right. Older adults are particularly vulnerable to life-threatening bleeding complications. The drug requires relentless monitoring.
The nursing implications are literally a masterclass in vigilance.
They have to be. Because heparin binds non-specifically to plasma proteins and macrophages, its biological effect varies wildly from patient to patient.
And even within the same patient from hour to hour, right?
Yes. To manage this, nurses constantly monitor a specific laboratory value called the APTT, the activated partial thromboplastin time.
This test measures the exact number of seconds it takes for a sample of a patient's blood to form a clot in a test tube.
Right. A normal healthy control value for someone not on medication is roughly 25 to 35 seconds.
So when a patient is on a therapeutic heparin drip, what's the goal?
The clinical goal is to prolong that clotting time to 1.5 to 2.5 times their normal baseline. The nurse is constantly titrating the IV drip rate, adjusting the dosage by minute fractions to keep that patient's blood clotting somewhere between 45 to 70 seconds.
That is a microscopic therapeutic window.
It is. If the APTT drops below 45, the patient is subtherapeutic. The clot grows, and they could die of a pulmonary embolism.
And if the APTT drifts above 70?
They become supratherapeutic, and they run the risk of spontaneous, fatal, intracranial, or gastrointestinal hemorrhage.
Incredible pressure on the nursing staff.
Yeah.
And beyond the bleeding risk, there is a specific paradoxical nightmare scenario associated with this drug. Heparin can trigger a deadly condition called HIT, heparin-induced thrombocytopenia.
Yeah, this one is tough to wrap your head around at first.
Right, because how does an anticoagulant trigger a massive clotting crisis?
This requires understanding the immune system's occasional misfires. HIT is not a dosing error. It is an immune-mediated adverse drug reaction.
Okay, so an allergy.
Kind of. It occurs in roughly 1% to 3% of patients who receive heparin for an extended duration, typically 4 to 14 days into therapy. For reasons not entirely understood, the patient's immune system starts recognizing the heparin protein complexes as safe.
So the body attacks it.
Right. The body synthesizes Ig antibodies against the heparin, and these antibodies bind directly to the surface of the patient's platelets, hyperactivating them.
Oh, no.
Yeah. The platelets go completely rogue, clumping together all over the body, forming highly dangerous arterial and venous microclots.
And because the body is suddenly consuming all of its free-floating platelets to build these rogue clots, the overall number of available platelets in the bloodstream plummets.
Exactly. And that drop in platelet count is the thrombocytopenia.
It sounds like a profound medical emergency.
It is. The moment HIT is suspected, which is usually signaled by an unexplained drop in platelet count of 50% or more, the healthcare team must instantly discontinue all forms of heparin.
Even the tiny flushes.
Yes, that includes the microscopic amounts used merely to flush 5E lines to keep them patent. They must pivot immediately to a completely different class of anticoagulant, such as a direct thrombin inhibitor like argatroban, to manage the cascading thrombosis.
Wow. So if a patient on a heparin drip begins to actively hemorrhage or their APTT shoots up to 120 seconds, what is the pharmacological safety net?
The primary antidote is a drug called protamine sulfate. It's essentially a chemical neutralization.
How does that work?
Well, heparin is an incredibly strong acid. Protamine sulfate is a strong base. When protamine is introduced into the bloodstream, it actively hunts down the heparin molecules, binds to them, forms an inert salt complex, and completely neutralizes the anticoagulant effect.
But the antidote itself is notoriously volatile, right?
Yeah.
I read there is a severe FDA box warning on protamine.
There is. If a nurse pushes that IV medication too rapidly, the patient can experience catastrophic cardiovascular collapse, severe hypotension, non-cardiogenic pulmonary edema, and intense pulmonary vasoconstriction.
So the very drug meant to save them from bleeding can throw them into anaphylactic shock.
Exactly. Which is why the administration protocol is ironclad. It must be given by a slow IV infusion over a minimum of 10 to 15 minutes, strictly in a clinical setting fully equipped for advanced cardiovascular resuscitation.
Let's transition to the other pillar of classic anticoagulation, warfarin.
Ah, warfarin.
If heparin is the fast-acting, volatile IV drug used in the acute hospital setting, warfarin, brand name Coumadin, is the oral pill patients take at home for years to manage their long-term risks.
Right.
But the history of warfarin is wild.
Yeah.
I mean, it wasn't developed in a sterile lab initially.
No, not at all. It was discovered in the 1920s when cattle in the Midwestern U.S. and Canada started mysteriously bleeding to death after eating spoiled sweet clover hay.
That is just bizarre.
It is. The fungal spoilage of the sweet clover naturally produced a compound called decumarol, which is a potent anticoagulant. Researchers isolated it, and initially it was actually synthesized and marketed in the 1940s as a highly effective, lethal rat poison.
From spoiled hay to rat poison.
To one of the most widely prescribed cardiovascular drugs in history. It wasn't until the 1950s that it was refined into a therapeutic drug for humans.
Its mechanism of action is incredibly clever, but it requires profound patience. Because unlike heparin, which acts directly on the blood circulating in your veins right now, warfarin acts entirely inside the liver.
Yes. It is the prototype vitamin K antagonist. To understand warfarin, you really have to understand the liver's manufacturing process.
Okay, walk us through it.
So, the liver requires vitamin K as an essential cofactor to synthesize 4 highly specific clotting factors. Factors 2, 7, time, X, and X. Warfarin's molecular structure closely mimics vitamin K.
So it's an imposter.
Exactly. It acts as a competitive antagonist, binding to the enzyme vitamin K epoxide reductase. It sneaks into the liver's chemical processing plant and jams the machinery, effectively shutting down the production line for those 4 clotting factors.
But because it only halts the production of new factors, it does absolutely nothing to the clotting factors that have already been manufactured and are currently circulating in the plasma.
That's right. And this dictates its unique pharmacokinetic profile. Warfarin has a delayed onset of action, typically taking 3 to 5 days to reach therapeutic levels.
So you do not see the full clinical effect of the drug until the old existing clotting factors reach the end of their natural biological lifespan and are cleared from the body.
Yes. This is exactly why a patient hospitalized with a massive blood clot is often placed on a heparin drip for immediate protection while simultaneously starting warfarin pills.
Ah, so once the warfarin finally kicks in a few days later, the heparin drip is turned off.
We call it bridge therapy.
That makes total sense. Now, there's another massive pharmacokinetic hurdle with warfarin. It is 98% bound to plasma proteins, predominantly albumin.
The protein binding dynamic is critical. Think of albumin in the bloodstream as a fleet of school buses.
Okay, school buses.
When you swallow a warfarin pill, 98% of the drug molecules get on the bus. They are banned, inactive, and simply circulating. Only the 2% that remain off the bus, the free, unbound molecules, are pharmacologically active and able to enter the liver to block vitamin K.
So if you introduce a second drug into the patient's system, say a highly protein-bound antibiotic or even over-the-counter ibuprofen, that new drug wants a seat on the bus.
Exactly. And it has a higher affinity for the albumin, so it physically kicks the warfarin molecules out of their seats.
Suddenly, your free active warfarin levels jump from 2% to 4% or 6%.
Right. And a 2% increase doesn't sound like much, but mathematically, you have just doubled or tripled the amount of active anticoagulant in the patient's blood.
So the patient is instantly propelled into an extreme risk profile for a massive unprovoked hemorrhage.
Yes. And that dynamic explains why the drug interaction list for warfarin is practically a phone book. Managing warfarin is like walking a tightrope in a hurricane. It interacts with virtually every other medication.
But it's not just drugs, it's food. Since warfarin's entire job is to block vitamin K, the patient's diet becomes a pharmacological variable.
Oh, absolutely.
If a patient suddenly decides to eat a massive salad packed with kale, spinach, and broccoli, which are incredibly rich in vitamin K, they are flooding their liver with the exact biochemical fuel it needs to override the warfarin.
And the drug is rendered useless, and the patient forms a clot.
And we cannot ignore herbal supplements, right? St. John's wort and ginseng heavily induce the liver enzymes that metabolize warfarin, clearing it from the body faster and decreasing its effects.
Conversely, garlic, ginkgo biloba, cranberry juice, and green tea can inhibit those enzymes or possess their own antiplatelet properties, dramatically increasing the effects of warfarin and pushing the patient toward severe bleeding.
Which is why the FDA issued a severe box warning for warfarin, specifically regarding this risk of major or fatal bleeding. The nursing implications for monitoring are just relentless.
They are. Because of all these dietary and pharmacological variables, a patient's dose is never truly stable.
So instead of the APT used for heparin, warfarin requires monitoring the PT, the prothrombin time, which is mathematically standardized, into a value called the INR, the International Normalized Ratio.
Right. Patients on warfarin require constant, sometimes weekly, phlebotomy to check their INR. A healthy person not on medication has an INR of roughly 1.0.
And for a patient managing atrial fibrillation or a history of DVT.
The clinical target is usually an INR between 2.0 and 3.0. If the INR dips to 1.5, they are unprotected and risk a stroke. If the INR climbs to 5.0, they risk bleeding to death from a minor internal injury.
It's just an incredibly stressful balancing act. We also absolutely must highlight the pregnancy contraindications here, because unlike heparin, which is safe because it's too large to cross the placenta, warfarin easily crosses the placental barrier.
It is a highly known teratogen. It causes severe fetal embryopathy, bone deformities, and fatal fetal hemorrhage. It is absolutely unequivocally contraindicated in pregnancy.
So if a patient on warfarin arrives in the emergency department with life-threatening bleeding, say an intracranial hemorrhage after a fall, we have to reverse the drug.
Right. The slow antidote is administering exogenous vitamin K, usually intravenously, to flood the liver and restart the production of clotting factors.
But the liver needs 12 to 24 hours to synthesize enough factors to stop a massive bleed.
And 12 hours is way too long if the patient is bleeding into their brain.
Right. For urgent catastrophic hemorrhage, we need the heavy artillery. Prothrombin complex concentrate, or PCC, sold under the brand name Kcentra.
Kcentra is a phenomenal feat of pharmacological engineering. It is derived from pooled human plasma and contains concentrated therapeutic levels of all four of those missing vitamin K-dependent clotting factors, 2, 7, IX, and X, along with proteins C and S.
So instead of waiting for the liver to manufacture the rebar and welders, you are intravenously handing the body the finished, ready-to-use biological products.
Exactly. And because it's concentrated into a small volume, it doesn't require blood typing or the lengthy thawing process that fresh frozen plasma requires. You can push it fast.
But again, there is a severe box warning attached. When you instantly reverse the warfarin to stop the bleeding, you violently swing the biological pendulum back toward thrombosis.
You are plunging the patient into an immense thromboembolic risk. You are actively forcing the clinical team to choose between letting the patient exsanguinate on the table right now or stopping the bleed and rolling the dice on them, suffering a massive ischemic stroke tomorrow.
It requires agonizing clinical judgment.
It really does.
So this exhausting reality of the constant INR blood draws, the strict dietary limitations, the fear of drug interactions pushed medical pharmacology to evolve. Both patients and doctors desperately wanted a simpler pill.
They wanted the efficacy of warfarin with, fire and forget convenience.
Which brings us to the modern era of anticoagulants, the direct thrombin inhibitors and the direct factor XANI inhibitors.
These newer agents promise predictable pharmacokinetics, a fixed daily dose without the need for routine laboratory monitoring. No more weekly finger pricks, no more worrying about a spinach salad.
Let's examine dabigatran, brand name Pradaxa. It is the leading oral direct thrombin inhibitor. How does its mechanism differ from the indirect actions of heparin and warfarin?
Well, dabigatran doesn't bother with antithrombin III, and it doesn't mess with the liver's production lines. It attacks the welder directly.
Okay, straight to the source.
It is ingested as an inactive prodrug, which is then rapidly hydrolyzed by esterases in the blood plasma and liver into its active form. Once active, it specifically and reversibly binds directly to the thrombin molecule itself.
And what makes it incredibly potent is that it binds to both free-floating thrombin in the plasma and the thrombin that is already embedded and bound within an existing clot.
Yes. By completely neutralizing thrombin, it prevents the conversion of fibrinogen to fibrin. The rebar never gets fused.
It has become a massive tool for stroke prevention in patients with non-valvular atrial fibrillation. And the trade-off is exactly what patients wanted. No routine therapeutic drug monitoring required.
But that immense convenience masks a hidden danger.
Because the absence of monitoring breeds a false sense of security, right?
Exactly. The FDA issued an alert regarding a profound risk of thromboembolic events if a patient suddenly stops taking dabigatran prematurely.
Because patients aren't tethered to a clinic for blood tests, they might forget a few doses or stop taking the medication entirely because of financial cost.
Not realizing their stroke risk instantly skyrockets the moment the drug clears their system. There are also ongoing investigations into potential links between dabigatran and severe liver injury, requiring careful baseline assessment of hepatic function.
There's also a bizarre administration rule I notice in the source text. The drug comes in a capsule that must be swallowed perfectly whole.
Yeah, this is so important. If a patient decides to open the capsule to sprinkle it on applesauce or chews it, the pharmacokinetic absorption rate explodes by 75%.
That massive influx of the drug leads to a sudden, extreme bleeding risk.
Absolutely.
And if a severe bleed does occur, the specific antidote for dabigatran is a relatively new, highly engineered drug called didortisuzumab, or Praxbind.
Right. It's a humanized monoclonal antibody fragment designed to bind specifically to the dabigatran molecule and neutralize it instantly.
Alongside the direct thrombin inhibitors, pharmacology developed the direct factor inhibitors, such as rivaroxaban, brand name Xarelto, and apixaban Eliquis.
These drugs act slightly higher up the coagulation waterfall. They bind directly and selectively to factor XA.
And by neutralizing factor XA, they completely shut down the pathway that generates thrombin in the first place.
Exactly. Again, we see fixed dosing and no INR monitoring required.
But rivaroxaban brings its own strict pharmacokinetic rules. To ensure proper absorption, the 15 and 20 milligram tablets must be taken with food.
Specifically for patients managing atrial fibrillation, it must be taken with the evening meal.
Both rivaroxaban and apixaban are heavily metabolized by the liver and excreted by the kidneys, rendering them strictly contraindicated in patients with severe hepatic or renal impairment.
But the critical safety alert, the box warning that every clinician and patient must memorize, revolves around the spinal column.
Yes, both rivaroxaban and apixaban carry a profound warning regarding the risk of epidural or spinal hematomas.
The anatomical implications of this are terrifying.
Because if a patient taking one of these drugs requires a spinal puncture for diagnostic fluid or an epidural catheter for pain management during surgery or labor, the puncture needle has to pass through the intricate venous plexus surrounding the spinal cord.
Right. And if the blood cannot clot, that tiny puncture can bleed continuously into the enclosed epidural space.
And the epidural space is encased in solid bone.
So the accumulating blood has nowhere to expand, so the hematoma begins to press inward, crushing the delicate nerve tissue of the spinal cord.
This compression can cause ischemia to the nerves, leading to rapid, permanent, and irreversible paralysis of the lower body.
Permanent paralysis from a routine epidural puncture simply because the drug was still active in their system.
The patient education here is critical. Patients must aggressively inform every single doctor, surgeon, and dentist that they're taking a factor XAT inhibitor before any invasive procedure is even considered.
And this highlights the massive clinical dilemma these modern drugs presented for years. They offered incredible convenience, but until the very recent development of specific reversal agents like andexanet alpha, they lacked reliable antidotes.
So if a patient came into the trauma bay hemorrhaging on rivaroxaban, the options were grim.
Very grim. Oral activated charcoal could be administered to bind the unabsorbed drug in the gut, but only if the timing was absolutely perfect, usually within 2 hours of ingestion. Beyond that, it was a terrifying waiting game.
We've spent this entire time navigating the sluggish, low-pressure veins. But if we pivot back to the high-pressure, turbulent arterial system, the rules of hemostasis change entirely.
They do. Arterial clots aren't mostly fibrin. They are predominantly made of aggregated platelets.
So manipulating the coagulation cascade with heparin or warfarin isn't the primary goal here. To prevent the arterial traffic jams that cause heart attacks and strokes, we need drugs that alter the behavior of the platelets themselves. We need to make them slippery.
We turn to the antiplatelet drugs. And the undisputed foundation of this class is aspirin.
Good old aspirin.
Aspirin is a cyclooxygenase inhibitor. It permanently acetylates the specific enzyme inside the platelet responsible for synthesizing thromboxane A2.
Okay, so if platelets use thromboxane A2, like a chemical distress flare to signal other platelets to clump together, aspirin permanently breaks the flare gun.
Exactly. Without thromboxane A2, that specific platelet is effectively blinded and silenced. It cannot aggregate. And what is truly remarkable is the duration of this effect.
A single tiny dose of aspirin permanently disables the cyclooxygenase enzyme for the entire biological lifespan of that platelet, which is roughly 7 to 10 days.
This means even after the aspirin molecule has been completely metabolized and cleared from the patient's bloodstream, those specific millions of platelets remain slippery and disabled until they naturally die, and the bone marrow manufactures fresh, unexposed replacements.
This is exactly why surgeons mandate that patients stop taking aspirin a full week before an elective surgery. They are waiting for a fresh batch of functional platelets to be born.
But aspirin is merely the baseline. Pharmacology developed a much more aggressive class of antiplatelets to combat arterial thrombosis, the ADP receptor antagonists.
The prototype of this class is clopidogrel, known universally as Plavix. Clopidogrel is an absolute staple in cardiovascular medicine, particularly for patients who have just had a metal stent deployed inside a coronary artery to keep it open after a heart attack.
Right. The body recognizes that metal stent as foreign damage, and the platelets want to aggressively clot around it.
Clopidogrel prevents that by irreversibly blocking the adenosine diphosphate, or ADP receptor, on the platelet surface. Like aspirin, this blockade lasts for the entire 7 to 10-day lifespan of the platelet.
But the pharmacokinetics of clopidogrel are highly complex, and for a specific subset of the population, they are lethally flawed.
Because clopidogrel is formulated as a prodrug, right?
Yes. When you swallow the pill, the compound entering your stomach is completely inert. It possesses zero antiplatelet activity. It must be absorbed into the blood, travel to the liver, and undergo a two-step oxidative activation process by a very specific cytochrome P450 enzyme called CYP2C19.
And only after the liver processes does it become the active metabolite capable of blocking the platelets.
Exactly.
And here is where human genetics turns this routine medication into a potential tragedy. I am looking at the FDA box warning for clopidogrel. Due to genetic polymorphism, roughly 2% to 14% of the United States population are classified as poor metabolizers of this drug.
Right. They carry a genetic variant that renders their CYP2C19 enzyme highly inefficient or entirely non-functional.
The clinical implications of that are terrifying. These poor metabolizers could be dutifully swallowing their clopidogrel pill every single morning after surviving a massive heart attack, fully believing they are protected.
But because their liver lacks the chemical machinery to unlock the prodrug, the active metabolite is never formed. They're receiving absolutely zero antiplatelet protection.
They remain at an extreme silent risk for a fatal stent thrombosis or a recurrent myocardial infarction. That is the ultimate pharmacological betrayal. How do clinicians navigate that genetic minefield?
Genomic testing exists. We can perform a cheek swab or blood test to identify these CYP2C19 poor metabolizers. However, due to the logistical delays and financial costs of rapid genetic sequencing, it is not yet a universal, routine standard of care before prescribing the drug.
So what's the alternative?
Instead, if a patient is a known poor metabolizer, or if the cardiologist wants to bypass the genetic risk entirely, they utilize alternative drugs in the same class. Prasugrel, for example, is a more potent ADP receptor antagonist.
It is also a prodrug, but its activation relies on a much faster single-step hepatic process that is far less susceptible to genetic variations.
Or they turn to ticagrelor, brand name Brilinta.
Ticagrelor is a fascinating chemical departure. Unlike clopidogrel and prasugrel, which permanently damage the platelet, ticagrelor binds reversibly to the ADP receptor.
Furthermore, it is not a prodrug. It is active the moment it hits the bloodstream, entirely bypassing the hepatic genetic lottery. But this rapid potency comes with its own severe FDA box warning.
The bleeding risk with ticagrelor is immense. It can precipitate significant, sometimes fatal hemorrhage. And the FDA warning is incredibly explicit regarding the clinical management of that bleeding. Do not discontinue the drug for bleeding if the bleeding can possibly be managed by any other localized means.
The reasoning is rooted in the rebound effect. If you suddenly withdraw ticagrelor from a patient with a fresh coronary stent to stop a nosebleed or a gastrointestinal bleed, the platelets rapidly regain their function.
The subsequent risk of the patient suffering a massive fatal cardiovascular event, like the stent suddenly clotting entirely shut, is statistically far worse than the morbidity of the bleeding itself.
It is the ultimate clinical rock in a hard place, and there is no chemical antidote for clopidogrel or prasugrel. If a patient on these drugs requires emergency surgery or suffers an intracranial hemorrhage, you cannot give them a reversal agent.
The only option is to intravenously transfuse them with bags of fresh, unexposed platelets from a blood donor to overwhelm the drug's effects.
Before we conclude our discussion on antiplatelets, we must briefly detail two highly specialized agents. The first are the glycoprotein IBA inhibitors, represented by abciximab.
These are the incredibly heavy intravenous antiplatelets used almost exclusively in the highly controlled environment of the cardiac catheterization lab.
Exactly. Abciximab is actually a highly engineered monoclonal antibody. Its mechanism is blunt force trauma to the platelets aggregation process. It binds directly to the GP-IBA receptors on the surface of the platelets, physically and completely blocking fibrinogen and von Willebrand factor from attaching.
It renders the platelets completely incapable of cross-linking.
Yes, it is utilized during percutaneous transluminal coronary angioplasty when the cardiologist is inflating balloons and deploying stents inside the arteries to ensure the traumatized vessel doesn't instantly clot off while they are working inside it.
Lastly, we have cilostazol. This agent is primarily utilized to treat intermittent claudication, the severe cramping leg pain caused by peripheral arterial disease, where narrowed arteries fail to deliver enough oxygen to the leg muscles during exertion.
Cilostazol is a phosphodiesterase inhibitor. It promotes vasodilation to widen the arteries and simultaneously inhibits platelet aggregation.
But the safety alert here is critical. Cilostazol carries a box warning, strictly contraindicating its use in patients with heart failure of any severity.
It has been shown to decrease survival rates in patients with congestive heart failure due to its phosphodiesterase inhibiting properties. It is a strict line drawn in the pharmacological sand.
We've spent this hour exploring how to stop venous clots from expanding with anticoagulants and how to prevent arterial clots from forming with antiplatelets. But we must confront the ultimate clinical nightmare.
What happens when prevention completely fails?
Exactly. What happens when a massive clot is currently, at this very second, blocking a coronary artery causing an active myocardial infarction or blocking a cerebral artery causing an acute ischemic strike?
We do not have the luxury of time. We cannot wait days or weeks for the body's natural plasmin to slowly digest the clot. Myocardial tissue and cerebral neurons are dying by the million every single minute they are deprived of oxygen.
We need the nuclear option.
We need drugs that don't just manipulate future clotting, but actively chemically obliterate the existing fibrin architecture. We turn to the thrombolytics.
The clot busters, the apex predators of this pharmacological text. The prototypes here are alteplase, also known as recombinant tissue plasminogen activator, or RTPA, and its structurally modified cousin, tenecteplase.
These agents are synthetic, hyperconcentrated versions of the body's natural clot-dissolving enzyme activators. When administered via rapid intravenous infusion, Alteplase dives straight into the bloodstream, actively seeks out the clot, binds directly to the fibrin rebar, and aggressively stimulates the conversion of the trapped plasminogen into active plasmin.
It is rapidly hyperactivating the natural process we discussed at the very beginning.
Yes. The localized plasmin then essentially acts as biological acid, aggressively digesting and shredding the fibrin framework of the clot from the inside out, restoring blood flow to the starving tissues.
If normal hemostasis is a road repair crew and thrombolytics are the intervention, this is akin to utilizing high-yield chemical explosives to violently clear an avalanche that is blocking a major interstate highway.
That's a great way to think about it.
Yes, the explosion will clear the obstruction and allow traffic to flow again, but the explosive force itself is violently dangerous, indiscriminate, and possesses a high probability of damaging the surrounding infrastructure.
The pharmacokinetics of Alteplase are entirely engineered for this rapid, violent intervention. It is built for intense speed. It has an extremely rapid metabolic clearance rate.
More than 80% of the drug is cleared from the bloodstream within 10 minutes of stopping the IV infusion.
Right. It hits the clot with overwhelming force, initiates fibrinolysis, and rapidly vanishes.
But the clinical risks are astronomical. When we talk about utilizing Alteplase for an acute ischemic stroke, we are operating within a terrifying high-stakes timeline. The American Heart Association and the American Stroke Association guidelines mandate a mercilessly strict time window.
The drug must be administered within 3 to 4.5 hours from the exact onset of the patient's stroke symptoms.
That time window is rooted in brutal physiology. When an artery in the brain is blocked, there's a core area of brain tissue that dies almost immediately.
Right, and surrounding that dead core is the penumbra, an area of highly stressed, starving neurons that are clinging to life.
The goal of Alteplase is to clear the clot and save the penumbra. But after 4.5 hours, the fragile vasculature of that starving penumbra has degraded too far. The tissue is necrotic.
If you administer the clot buster after that window closes, you aren't saving tissue. You are just suddenly blasting high-pressure arterial blood flow back into a massive area of dead, fragile, necrotic brain tissue.
The vessels instantly rupture, converting an ischemic stroke into a massive, catastrophic hemorrhagic stroke.
The data is sobering. There is a roughly 3% overall mortality rate directly associated with the administration of the drug itself, and a 6% to 8% risk of inducing a symptomatic, highly dangerous hemorrhage in the brain.
You are injecting a drug into a patient's veins to save their brain, knowing full well it carries a 1 in 15 chance of causing a catastrophic bleed inside their skull. That demands immense clinical respect.
It explains why the contraindications for Alteplase are the strictest in modern medicine. The screening process in the emergency department must occur in minutes, but it must be flawless.
You absolutely cannot administer Alteplase to a patient presenting with severe, uncontrolled hypertension because the pressure will cause bleeding.
You cannot give it to a patient who has had recent intracranial trauma, recent major surgery, a known history of bleeding disorders, or who is currently taking high-dose oral anticoagulants. Any of those factors guarantees a massive hemorrhage.
The nursing implications dictate a protocol of hypervigilance. Before the Alteplase 7 line is ever opened, the nurse must draw and verify a baseline INR, APTT, platelet count, and fibrinogen level.
The drug must be administered through a highly controlled, dedicated IV pump, and there is a massive procedural mandate. Once a patient is on thrombolytics, there are absolutely 0 intramuscular injections allowed, no exceptions.
Because if a nurse were to push a needle deep into the muscle tissue of a patient receiving Alteplase, they would create a puncture wound in an environment entirely devoid of clotting ability.
The patient would bleed continuously into the deep fascia, developing a massive, hidden, exsanguinating hematoma inside the muscle.
Furthermore, when Alteplase is utilized to dissolve a clot, causing a myocardial infarction, the nursing team must monitor the patient's electrocardiogram with absolute intensity for reperfusion dysrhythmias.
Because when the clot dissolves and freshly oxygenated blood suddenly violently rushes back into heart tissue that has been suffocating and electrically unstable, the heart's electrical conduction system can short-circuit.
The sudden influx of oxygen generates free radicals, causing chaotic electrical signals, often triggering dangerous arrhythmias like ventricular tachycardia.
It is a controlled clinical chaos aimed at snatching a patient back from the brink of severe disability or death.
Which brings us perfectly to our final segment. We need to examine the safety net. The overarching theme of every single molecule we have discussed today, from the classic heparin to the genetic complexities of clopidogrel to the explosive force of alteplase, is the existence of a razor-thin therapeutic window.
The biological line between preventing a stroke and causing a fatal hemorrhage is microscopic.
So when that window shatters, how do medical professionals hit the brakes? We've touched on several antidotes, but let's synthesize this reversal arsenal and introduce the interventions for thrombolytic overdose.
We established that an overdose of heparin requires protamine sulfate, which chemically neutralizes the acid but carries the risk of cardiovascular collapse.
An overdose of warfarin utilizes slow IV vitamin K, or for urgent, life-threatening bleeds, the rapid administration of prothrombin complex concentrate, Kcentra.
If a patient overdoses on the oral direct thrombin inhibitor dabigatran, we deploy the targeted monoclonal antibody udartizumab, Prexbind.
But what if the nuclear option goes wrong? What if alteplase triggers a massive systemic hemorrhage?
For severe bleeding induced by thrombolytics, the pharmacological toolkit turns to systemic hemostatic agents. The primary agents are aminocaproic acid, brand name Amicar, and tranexamic acid, widely known as TXA.
How do they stop the bleeding?
They directly inhibit plasmin. They are essentially antifibrinolytic agents. They halt the hyperfibrinolysis by binding to the plasminogen and plasmin molecules, preventing them from attaching to the fibrin rebar. They lock down the clot and protect it from further destruction.
TXA is incredibly versatile. Beyond reversing alteplase, it is heavily utilized in trauma bays to manage massive hemorrhage. And the text notes it is even used proactively for short durations in patients with hemophilia to prevent severe bleeding during routine procedures like tooth extractions.
But I want to circle back and linger on the profound analysis you offered earlier regarding Kcentra because it applies to this entire safety net. Antidotes and reversal agents are not a free pass. They do not magically reset the patient to zero.
They are the ultimate desperate trade-off. When you push an antidote into a patient's via, whether it is Kcentra, protamine, or Prexbind, you are violently, artificially swinging the biological pendulum from an actively bleeding state straight back into a highly prothrombotic clotting state.
The underlying pathology that necessitated the blood thinner in the first place, the chaotic electrical currents of atrial fibrillation, the turbulent flow across a mechanical heart valve, the pooling blood of a massive DVT, that disease state has not vanished. It is still right there.
So by administering the antidote to stop the active bleeding, you are instantly placing the patient directly back into the crosshairs of a fatal stroke or a pulmonary embolism. It is choosing the lesser of two immediate evils.
You either let the patient bleed to death on the table right now, or you stop the bleeding and pray their native pathology doesn't throw a massive clot to their brain later tonight. It demands an immense, terrifying level of clinical judgment from the physician.
And it highlights why patient education is arguably the most powerful, vital tool we possess to prevent these life or death crises from ever materializing in the first place.
Let's construct the listener's toolkit. For anyone who is caring for an aging relative on a blood thinner, or perhaps navigating these medications themselves, the daily reality requires absolute, unbroken vigilance. The safety precautions are paramount and non-negotiable.
The clinical guidelines outline a strict reality for these patients. They must utilize a soft, bristle toothbrush to prevent the minor gum trauma that could escalate into a continuous oral bleed.
They must transition exclusively to electric razors instead of traditional blades to eliminate the risk of facial lacerations.
They absolutely cannot walk barefoot indoors or outdoors because a simple, unnoticed cut on the heel from a piece of glass could slowly pool into a massive, limb-threatening hematoma.
Dietary consistency is absolutely crucial, particularly for patients managing warfarin. The goal isn't necessarily a punitive restriction where they can never eat a leaf of spinach or vitamin K again.
The objective is rigorous consistency. Keeping their dietary intake exactly the same every single day ensures the baseline vitamin K levels remain stable, allowing the physician to calibrate the warfarin dosage perfectly against it.
And the impact of smoking cessation cannot be overstated. Tobacco smoke dramatically alters the hepatic enzymes responsible for clearing warfarin from the body.
If a patient suddenly decides to quit smoking, the metabolic clearance of the drug slows down, their warfarin levels can unpredictably spike, and they require an immediate dosage reduction to prevent a hemorrhage.
They must wear a MedAlert bracelet at all times. Emergency medical responders need to know instantly if a trauma patient is chemically incapable of forming a clot.
And there is the absolute ironclad necessity of informing every single doctor, dentist, pharmacist, and physical therapist about these medications prior to any procedure, no matter how seemingly minor.
A routine dental cleaning involving deep scaling could become a hemorrhage requiring hospitalization.
A routine epidural puncture for a patient managing a minor DVT on rivaroxaban could precipitate the spinal hematoma we discussed, causing permanent lower body paralysis.
Managing coagulation is a shared, continuous responsibility between the patient, their family, and the entire healthcare team. The margin for error is simply too narrow to navigate alone.
So, what does this vast, complex journey all mean? We have traveled from the microscopic aggregation of a single activated platelet responding to damaged collagen to the systemic life-saving and highly volatile chemical interventions used in modern trauma bays.
We have decoded how manipulating the intricate coagulation waterfall requires immense pharmacological precision, relentless laboratory monitoring of INR and APTT, and a profound, humbling respect for the body's natural balance.
We have observed the sheer evolutionary arc of medical science, moving from extracting heparin from the lungs of cattle, to isolating warfarin from spoiled sweet clover, to mapping the exact genetic variations of the CYP2C19 enzyme, to engineering incredibly specific monoclonal antibodies like abciximab and lediricizumab in high-tech laboratories.
Whether you are a nursing student prepping for an intense pharmacology exam, a family member nervously caring for a relative on a liquid, or just deeply curious about the immense power contained within the tiny pills sitting in your medicine cabinet, understanding this biological balancing act provides you with a profound respect for human physiology.
It reveals the breathtaking complexity of our bodies attempting to protect us, and the extreme lengths science must go to in order to modulate that protection safely.
And I want to leave you, the listener, with a final provocative thought to ponder as we close out today's deep dive.
We learned today that up to 14% of the population carries a genetic variation that renders the crucial, widely prescribed antiplatelet drug clopidogrel effectively useless inside their bodies.
That implies that right now, as you listen to this, there are thousands of people who might be religiously swallowing a pill to prevent a fatal heart attack, a pill that their body physically lacks the chemical machinery to activate.
As advanced genomic testing becomes cheaper, faster, and universally accessible, are we rapidly approaching a threshold where the era of trial and error with these incredibly dangerous blood thinners finally ends?
Are we looking at a near future where the standard of care is replaced by a simple 2-minute cheek swab in the cardiologist's office, a test that maps your exact enzymatic profile and dictates your perfect, personalized, genetically matched, life-saving prescription from day one?
It is a pharmacological future that could systematically eliminate the terrifying guesswork for poor metabolizers, fundamentally shifting the paradigm of cardiovascular care and saving countless lives.
It's incredible to visualize, and it brings us full circle right back to where we started.
Usually when we contemplate the body healing itself, we expect that comforting simplicity. A minor paper cut scabs over. It's clean, binary, and safe.
But as we have uncovered today, the exact same microscopic machinery patching that minor scrape is the same powerful, murky, and chaotic biological force entirely capable of stopping a beating heart or shutting down a brain.
It is the ultimate biological paradox, and successfully navigating it requires nothing less than absolute pharmacological mastery.